A very good morning to you students. Now today we are going to discuss about the and what is angina, what is the treatment of angina, myocardial infarction, also commonly known as heart attack, and heart failure. We will know about these three different terms and the treatment of these diseases in very brief. So let us start with the first topic, angina pectoris. Basically, what is angina? Angina is diagnosed with a sudden severe pressing chest pain. This pain usually starts substernally and radiates to left arm. Now, this is how you diagnose. The patient will come with a complaint of chest pain and often radiating to left arm. What is the reason of this pain? It occurs when there is imbalance between the myocardial oxygen demand and oxygen supply. The heart is not able to supply the blood properly, then pain occurs and it is called angina pectoris because it is felt behind the pectoral girdle. Risk factors associated with angina pectoris is increased age, obesity, smoking, diabetes. Now, classification of angina. We can classify angina on the basis of when it develops. First one is exertional angina. It occurs when their person do extra work, means do the exercise. That is why it is known as exertional angina, more than usual work. It is basically also known as classical angina, atherosclerotic angina, or stable angina. The basic pathophysiology behind this type of angina, exertional angina, is that it occurs due to the obstruction of coronary arteries, which are responsible for the supply of blood to the heart itself by atheroma, means an obstruction. Second type of angina is variant या vasospastic angina. In this type of angina, there is no physical obstruction, but at times the coronary arteries themselves undergo spasm, and as a result of this spasm, the blood supply to the heart is decreased and it causes the angina. That is why it is known as vaso, means vessels, vasospastic angina. Third one is unstable angina. Unstable angina, it is the combination of both stable and variant angina. Partly there is obstruction and partial there is spasm. Now we come to the treatment. We have another classification of angina known as acute or chronic, depending on the timing of attack, timing of development of angina. Now we come to the treatment of angina. Basically, there are drugs which are known as nitrates and nitrites. The preparations available are they can be given by sublingual route, inhalation route, short and oral in case of longer acting drugs. On the basis of duration, we have short acting drugs. The action starts within few minutes and total duration of action is 15 to 30 minutes. Example is nitroglycerin, glyceryl trinitrate. These are the drugs which are preferred in the acute attack of angina and are used as sublingual tablets. Whenever there is an acute attack of angina, the person is asked to take this tablet and keep it below the tongue for the absorption. Second is isosorbate dinitrate. It is used as a sublingual spray. And third one is amyl nitrite. It is used by inhalation route and again it produces the rapid action. For longer acting drugs like nitroglycerin, isosorbide mononitrate, erythritol tetranitrate, they are used for the chronic and are given orally as an ointment, buccal, root, transdermal patch is also available, and at times they can be given parenterally also. And here it is important to see that isosorbate mononitrate belongs to the longer acting group, whereas isosorbate dinitrate, it is a faster acting absorption. They are well absorbed according to the route and the purpose that is required. GIT is used for the longer acting drug, sublingual for the shorter acting and faster action, inhalation for again the faster action, and transdermal for the longer action. Metabolism, they are metabolized through the first pass metabolism, and that is why shorter acting have a low oral bioavailability and have to be given by sublingual or inhalation route. When these are metabolized, two types of metabolites are produced, dinitro and mononitro. Dinitroforms are active metabolites and has significant vasodilator action also due to the production of nitric oxide. Metabolism. Dinitrate metabolite is an active metabolite. It is used clinically and they are excreted through kidney. Mechanism of action. How do these nitrates they work? They basically work by releasing the nitric oxide. This nitric oxide, it increases the cGMP and cGMP level. It dephosphorylates the myosin. When there is dephosphorylation of myosin light chain, it cannot combine with the actin to form the complex, and hence the muscle relaxation occurs. Because the treatment here is to relax the muscle in case of vasospastic angina and unstable angina. It is also useful in stable angina. As so, the pharmacological actions are nitrates, they relax all types of smooth muscles. It acts not only on the heart muscles or the vessels muscle, blood vessel muscles, but all type of smooth muscles, vascular or non-vascular. They relax both the arteries and veins, but comparatively have more action on the veins. They act only on the smooth muscles and not on the cardiac or skeletal muscles. As I have already told you, nitric oxide release stimulate the guanylyl cyclase, and in platelets, this increase in cGMP is responsible for the decreased platelet aggregation, and this is the reason why it is useful in classical angina, because platelet aggregation is lesser. And clinical uses are nitrates shorter acting for acute attacks, longer acting for prophylactic, because they take their action starts a little later, that is why they are used for prophylactic. However, nitrates are used in all treatment of all types of angina. Angina of effort, it is also known as exertional angina. The main aim of therapy in this case is to decrease the venous return. If less blood returns to the heart will have to work less to pump that blood further. So these nitrates, they help by decreasing the venous return as well as by decreasing the arterial blood pressure. If there will be less arterial blood pressure, the heart will again will have to work less, because both this decreased venous return as well as decreased arterial blood pressure, they decrease the myocardial oxygen requirement. In case of variant angina, they relax the smooth muscle of epicardial coronary artery and relieve coronary spasm. Unstable angina, they relieve the coronary spasm as well as decrease the platelet aggregation. So, nitrates, they are useful in all type of angina, all the three types: classical, variant as well as unstable angina. Main adverse effects of this group are orthostatic hypotension, because they relax the vascular muscles. So orthostatic hypotension is a pharmacologically related adverse effect. They relax the cranial vessels, so throbbing headache is the main complaint. In fact, we ask the person to spit the sublingual nitroglycerin, as it indicates the toxicity. Tachycardia may be there. Facial cutaneous flushing is there. Tolerance and dependence, they are the two important adverse effects. Tolerance means if we continue it for a longer period, then the person will start showing the less effect, and if this is in within minutes or hours, then within minutes, then it is called tachyphylaxis. That is why we never give the drug nitrates or apply the patch continuously. We give a break when we apply the transdermal patch, and do not play at least 6 to 8 hours drug free interval is required to prevent the development of tolerance. And dependence is if we withdraw the drug abruptly, then it produces side effects. That is why again we have to withdraw the drug slowly. Salt and water retention, carcinogenicity and methemoglobinemia, they are the main adverse effects with nitrates. But nitrites, they use it for this property of methemoglobinemia only. We use them in cyanide poisoning. Now, contraindications of nitrates. They are contraindicated in increased cranial pressure and intraocular, but they can be used safely in intraocular pressure. So this was the first group, nitrates. Second group used in anti-anginal treatment is calcium channel blockers. They block the calcium entry in myocardium. When there is less calcium, the contractility will be less, and as the contractility requires the oxygen, so less oxygen demand, heartbeat will also decrease, again causing the less oxygen demand. And this is the mechanism by which calcium channel blockers are beneficial in angina. Another mechanism effective on vessels is that they decrease the peripheral resistance. Means calcium channel blockers, they act on the heart as well as on the vessels to decrease the overall oxygen requirement. They are used in all types of angina, but very effective, most effective in variant type of angina. Third group is beta blockers. They are not vasodilators, but they decrease the heart rate and myocardial contractility, decreasing the oxygen requirement. So they act mainly on the heart, not on the vessels. They are useful in classic and unstable angina but are not useful in variant angina. Because if we give the non-selective beta blockers, then vasodilator beta 2 receptors will also be blocked and the spasm will be increased. So they are not used in variant angina but in classic and unstable angina. Whereas the previous two groups, nitrates and calcium channel blockers, were used in all types of angina. However, they are effective in treatment of silent or ambulatory angina. We call the angina is silent when there is no pain, because initially we had discussed that angina presents mostly as a substernal pain, but at times there is no pain felt by the patient. This is called silent angina, and beta blockers, they are very effective in this type of angina. Next, fourth group is potassium channel openers, nicorandil. The more potassium will be available because they are opening the potassium channels. Nitric oxide will be released, arterial venodilators, but they are used only as a prophylactic therapy, may cause the headache, flushing, dizziness. Nicorandil is the name of this drug which belongs to potassium channel opener. So we have discussed four groups. Nitrates were short acting or longer acting. Shorter acting for the acute angina, longer acting for the chronic angina. Second group was beta blockers. It was used in silent angina but not in variant angina. Calcium channel blockers, they were used in all three types of angina. And potassium channel opener, which is mainly used as a prophylactic therapy. Besides these four groups, we have other anti-anginal drugs also, like trimetazidine, ivabradine, ranolazine, dipyridamole. Dipyridamole, they relax the coronary vessels, but the disadvantage is that they relax the vessels where to increase the blood supply where it is not required in the heart. So it is of no use, and it is also known as coronary steel phenomenon by dipyridamole. Trimetazidine, they shift the use of fatty acid to glucose for the energy in the heart. It benefits by decreasing the oxygen requirement, as oxidation of fatty acids require more oxygen in comparison to the oxidation of glucose. Ivabradine is a directly acting drug on the heart which decreases the heart rate. So these 3-4 drugs, they belong to the other anti-anginal drugs. Now, treatment of angina. Acute attack, short acting nitrates or nitrites, they are the effective, given by sublingual or inhalation route. For prophylaxis, we have all the other drugs, longer acting nitrates, calcium channel blockers, beta blockers, and potassium channel openers, along with the other anti-anginal drugs. Now, combination therapy. Can we combine all these drugs? Yes. The disadvantage of one drug is counteracted by the opposed by the other drug. For example, nitrates, they dilate the vessels and increase the heart rate reflexively, whereas beta adrenoreceptors, they do not act on the vessels but decrease the heart rate. So they are beneficial. This combination is beneficial. Calcium channel blockers and beta blockers, both they decrease the heart rate, calcium channel blockers, verapamil especially. So they are usually not combined, with the exception if the calcium channel blocker is dihydropyridine, means nifedipine, nicardipine, जिनमें भी लास्ट में पिडीन आता है, they all belong to the dihydropyridine group. They can be only those drugs can be combined with the beta blockers. Calcium channel blockers and nitrates can again be combined with each other, and if it is not controlled by the two drugs, then all three can be combined together to control the angina. Of course, for the surgical therapy, next step is surgical therapy, where we do the coronary bypass and balloon therapy. This was all about the angina. Now we come to the next topic, heart failure. So heart failure, before we start the heart failure, I will like to touch upon the myocardial infarction. The difference between the angina and myocardial infarction is that angina is a reversible condition till the damage to the heart is reversible if the oxygen supply is restored, whereas myocardial infarction is irreversible stage. Next stage, you can say, when the damage has occurred to an extent that it cannot be normalized without any sequelae. So this is known as MI. For the treatment of MI may be, it presents with the same angina like pain, and many times there are thrombi formation and embolization of thrombus occurs, and it causes the damage to the site where it reaches, like in brain, kidney. So तो पेशेंट के अंदर सबसे पहले वी हैव टू treat according to the symptoms. First, maintain the airway, blood pressure, and then to relieve the pain, anxiety and apprehension, an opioid analgesic or diazepam, means sedative hypnotic, is given. Then if there is acidosis in blood due to excess of lactic acid production, then it is corrected by giving the IV sodium bicarbonate. For arrhythmias, because arrhythmias, they are the common features in MI and more chances immediately after the MI. So depending if it is tachyarrhythmias, then beta blockers are given. Beta blockers will also help to decrease the infarct size, and lidocaine, procainamide, they can also be used. If it was the bradycardia, means decreased heart rate or heart block was there, then it is managed by giving the atropine or electrical pacing. For pump failure, if this heart failure sign symptoms also again present along with the MI, then we give the diuretics like furosemide, vasodilators, or inotropic drugs like dopamine, dobutamine. To prevent the thrombus extension, we give the aspirin, antiplatelet drug. Anticoagulants may be required to prevent the deep vein thrombosis, like anticoagulants like heparin, fondaparinux. ठीक है, और अगर अब थ्रोम्बस बन ही गया है तो वी हैव टू डिजॉल्व इट बाय गिविंग द fibrinolytic agents like streptokinase, altiplase. And lastly, for the chronic benefits, we give the ACE inhibitors angiotensin receptor blockers, statins to control the lipid levels, beta blockers. These 3-4 drugs, ACE inhibitors, beta blockers, they also prevent the remodeling, and remodeling is not a beneficial, it is harmful in case of heart, so we have to prevent it by giving these drugs. Now we come to our topic of हार्ट फेलियर. ठीक है, एंजाइना के अंदर तो क्या था, हार्ट को खुद को सप्लाई कम मिल रही थी, एंड दैट इज़ वाई इट वॉज सफरिंग फ्रॉम पेन. वेयर एज इन CHF, whole of the body is getting the less blood supply, and it is not because of the decreased volume, it is because of the heart inability of the heart to pump. इसको कहते हैं कंजस्टिव हार्ट फेलियर. ठीक है, कंजस्टिव हार्ट फेलियर में जो साइन सिम्टम्स आते हैं, दे बेसिकली डिपेंड ऑन द congestion. If there is congestion at the periphery, then it can present with the edema, swelling, and if it is in lung, then it can present with dyspnea. So what is a failing heart? It is the inability of the heart to pump sufficient blood to meet the metabolic demands of the body. ठीक है, इसमें हार्ट खुद पंप नहीं कर पा रहा है. इट कैन बी सिस्टोलिक, डायस्टोलिक. Two types. Systolic is when there is ineffective contraction. ठीक है, and diastolic is when there is ineffective relaxation, and because the heart receives blood during the diastole, and if there is ineffective diastolic, then heart will not receive the proper amount of blood and it will not be able to pump it forward. So overall if we see, it is the reduced efficiency of the heart as a pump, and the result is decreased cardiac output. The body parts will not get sufficient blood and hence the oxygen. So what we need to do in this condition, we want to increase the heart contraction, and for this we use the inotropic drugs. Here it is important to know the difference between the inotropic and cardiac stimulant drugs. Inotropic drugs, they increase the force of contraction and cardiac output without increasing the oxygen consumption. Whereas cardiac stimulant drugs, they increase the heart rate also, and increased heart rate increases the oxygen consumption also. So they are known as cardiotonic or inotropic drugs. Hence, you can see in the slide also, in its contrast, symptommimetics or cardiac stimulants, they increase the heart rate and oxygen consumption without increase in cardiac output. Myocardial efficiency is increased by inotropic drugs. Now we have two types of heart failure, low output failure and high output failure. हाई आउटपुट फेलियर होता है जैसे पेरी हाइपोथायरायडिज्म, कार्सिनॉइड. इनमें हार्ट इज़ पंपिंग सफिशिएंट ब्लड but it is not effective for the body. Whenever a body does not get the sufficient supply of oxygen, then it tries to compensate. It is by sympathetic nervous system stimulation, a release of more adrenaline or adrenaline, but it will again increase the heart rate. Second is renin-angiotensin system is also activated, because when there is less cardiac output, less blood will reach to the kidneys and there will be less renal output, and it will activate the renin-angiotensin system. Third one is myocardial hypertrophy will be there in its effort to increase the contraction. And fourth is cardiac rhythm may be altered. So the sign and symptoms of CHF, they depend on the part affected more. If it was the lung, then shortness of breath. If there is lungs will be affected when there is heart failure of the left side mainly, and right is functioning uh, efficiently. Then there will be shortness of breath, weakness, fatigue will be there in all conditions. Um Awakening, shortness of breath at night, increased pillows at night to drain the lungs from excess of fluid, coughing, wheezing. If it was the left heart failure, if it was the right heart failure, then the blood will accumulate in the veins of the body periphery, and it will cause the swelling of feet, leg, other dependent areas, congestion of liver may damage the liver, so anorexia, loss of appetite. Symptoms may be common symptoms are fatigue, non-specific symptom, activity is decreased, less oxygen is available, less energy, edema of periphery, shortness of breath, and cough. So the treatment, what we will do first to relieve the congestive symptoms, then arrest, reverse the disease progression. Third are non pharmacological measures. ठीक है, inotropic drugs, congestion कैसे होगा? If it was more in the periphery causing the pedal edema, then we will get the diuretics, furosemide, thiazide. These parts are covered in another chapter. If it was heart failure was because of the high blood pressure, then we can give the arteriodilators. We will also give the other vasodilators. Beta blockers will be given to decrease the heart work. But the drugs used are main drugs that are used only in this group of heart are inotropic drugs, digoxin, dopamine, dobutamine, ambrinon, milrinone. They are the inotropic drugs which we will focus upon more. Reversal of disease progression is by beta blockers, ACE inhibitors, ARBs, as I have already told you in the MI part, aldosterone antagonist, spironolactone, and other non-pharmacological measures are rest and salt restriction. So, the pharmacotherapy of CHF, as you can see in the diagram, there are four classes. First one on the left side, asymptomatic left ventricular dysfunction, mild heart failure class 1, moderate class 2, severe class 3, refractory class 4, and emergent. As you can see, ACE inhibitors, they are the preferred drugs. They are used they are used in all the classes, class 1, 2, 3, 4, black demonstrated by the black line. ACE inhibitors. Beta blockers, they are started when in mild heart failure, and they are not much effective in severe and refractory heart. Whereas diuretics, they are started from the moderate heart failure and to severe, and not usually preferred in the mild heart failure. Digoxin, it used to be a first line drug some years before, but now it is a third line drug, and as you can see, it comes after the three major drugs: ACE inhibitors, beta blockers, and diuretics. Digoxin is used only in severe, at least moderate severe, to refractory emergent heart failure. Spironolactone is again used in the same scenario, and IV vasodilators and IV inotropes, they are the last resort in the treatment of heart failure. So these are the, again, as you can see in the diagram, these are the major drug classes: ACE inhibitors, beta blockers, diuretics, digoxin, spironolactone, vasodilators. Now digitalis. As I have already told you, we will focus more on the inotropic drugs: digitalis, dopamine, dobutamine, amrinol, milrinol. In this chapter, rest of all will be covered in different chapters, different classes. And so digitalis, it has direct effect on myocardial contractility. It has a vagomimetic action, means decreases the heart rate. And that is why it is beneficial. Positive inotropic effect, dose dependent increase in force of contraction. Systole is shortened and diastole is prolonged. More blood is received in the diastolic period, so more effective in that. As you can see in the diagram, this is the diagram. Heart failure can, you can see the bottom line. Heart is not able to pump. A top one is a normal, and digitalis is in between. It cannot bring it to absolutely normal, but can certainly improve the condition of heart failure. So this is the mechanism of digitalis. It seems to be a bit complicated, but is very easy. As we start with the first, initially, as you can see, there are some calcium channels, depolarization, where it is written. First point, increased calcium, either it is from the sarcoplasmic endoplasmic reticulum or ryanodine receptor. Increased calcium is necessary for the contraction, and contraction is the pumping of heart. And now you come to the part 5.5. Here we have sodium potassium ATPase. Sodium potassium, what is the role of sodium potassium ATPase? It is the main enzyme which is blocked by the digoxin. Sodium potassium ATPase, it sends the sodium outside and brings the potassium inside. Potassium is a relaxation, causes the relaxation. Because it is blocked by the digoxin, so potassium is not able to come inside and sodium is not able to go outside. This increased sodium will then indirectly increase the calcium inside, because there is no deficiency of sodium, so more sodium will not come, and calcium will not be removed by the sodium calcium exchanger. So indirectly it increases the calcium and increases the contractility of the heart. This is the main mechanism of digitalis. Pharmacokinetics. There are two drugs, digoxin, digitoxin. Digitoxin is most lipid soluble and they have a high volume of distribution. Cardiac glycosides. Digitalis is a drug which belongs to cardiac glycoside group, and it has a very large volume of distribution, so it will reach to the heart, skeletal muscle, kidney, all parts, and is accumulated there due to high lipid solubility. Digoxin is excreted primarily in urine, and rate of excretion parallels creatinine clearance. So if there is renal damage, its dose need to be controlled. Now come to the side effects. Side effects can be डिवाइडेड इंटू टू, एक्स्ट्रा कार्डिक और कार्डिक। एक्स्ट्रा कार्डिक के अंदर जीआईटी में सबसे ज़्यादा नोजिया, वॉमिटिंग, एनोरेक्सिया करके प्रेजेंट होता है। डिजिटलिस टॉक्सिसिटी होती है तो डिजिटलिस के एडवर्स इफेक्ट्स। देन सीएनएस के अंदर सीटीजेड स्टिमुलेशन, हेडेक, ब्लरिंग ऑफ विजन, फैटीग, मलेज, नो डिजायर टू वॉक। सीरम इलेक्ट्रोलाइट, पोटेशियम, hypokalemia, hyperkalemia. Hyperkalemia, it increases the chances of digitalis toxicity. So, there is one important thing to mention here, that if there is chronic digitalis toxicity, then we can give the potassium. But in acute, potassium is contraindicated from outside. Magnesium again increases the toxicity. Calcium. Cardiac arrhythmias, all types of arrhythmias can be generated by digoxin. Tachyarrhythmias, bradyarrhythmias, AV block. So treatment is according to the type of arrhythmia produced. As an adverse effect for tachyarrhythmias, we give the for chronic cases we give the potassium because there is potassium depletion. For acute we do not give the potassium. Instead do the potassium as serum potassium estimation to guide the therapy. For ventricular arrhythmias, lidocaine is given. For PSVT, paroxysmal supraventricular tachycardia, propranolol is given or adenosine, and for AV block, atropine is given. Contraindications are hypokalemia because it will increase the toxicity, MI, WPW syndrome because in ventricular tachycardia may be converted into ventricular fibrillation, partial AV block में complete block हो जाएगा, thyrotoxicosis में नहीं देते हैं. So these are the contraindications of digitalis. Drug interactions are seen with diuretics, calcium. Diuretics में hypokalemia हो जाता है, so इसमें साइड इफ़ेक्ट के चांसेस ज़्यादा हो जाएंगे. तो डायरेटिक्स दे रहे हैं तो साथ में पोटेशियम सप्लीमेंट देते हैं या फिर पोटेशियम स्पेयरिंग डायरेटिक्स देते हैं. Calcium also causes the contraction of heart, so synergistic action. Adrenergic drugs, they also produce the arrhythmia. Propranolol and calcium channel blockers, they depress the AV conduction and oppose the positive inotropic, so they should not be given with them. Metoclopramide, sucralfate and antacids, they decrease the absorption of digitalis, so they are not to be given with the drug within 2 hours of each other. Now digoxin digitalization, इसमें हम we have to maintain the digoxin level between 0.5 to 1.5 nanogram per milliliter, and पहले हम rapid IV देते थे digoxin. For that we used to give 0.25 milligram stat by slow IV and then 0.1 milligram every hourly. तो बहुत विदिन आवर्स आ जाता था, बट इट इज़ नॉट प्रेफर्ड नाउ बाय IV route. Now we prefer the slow digitalization by oral route, 0.25 milligram. Wait for 1 week. If we cannot see the effect, then 0.375, then again increase by 0.125 per week. And when to know when do we know that we have to stop increasing the dose if bradycardia occurs? Rapid digitalization, again we use oral route, not the IV route. For that we give 0.5 to 1 milligram stat and then 0.25 milligram every 6 hourly. So in digitalis, we know it is the main drug used in heart failure along with the many other drugs like diuretics, vasodilators, ACE inhibitors, beta blockers. ठीक है, because they and they act by inhibiting the enzyme sodium potassium ATPase. The side effects, they can be divided into cardiac and extracardiac. Anorexia, nausea, vomiting, they are the main first most common adverse effects. Bradycardia is an indication to stop increasing the dose. And another drugs are inotropic drugs besides digitalis are dobutamine, dopamine. Dobutamine is a selective beta 1 agonist. It is used in acute case of heart failure and MI, because many times after MI heart failure develops, and in cardiac surgery. Dopamine, it is used in cardiogenic shock due to MI, means MI followed by heart failure and cardiogenic shock. Heart failure known as, for it, dopamine acts on the D1 receptor. D1 receptors are present on the renal mesenteric vasodilatation. They will prevent the renal shutdown by increasing the GFR. Limitation of using the dopamine is it raises the systemic vascular resistance. Now a new group which has been added for the treatment of congestive heart failure and is very effective in the treatment is phosphodiesterase 3 inhibitors. The important drugs are ambrinon, milrinone. They are also known as inodilator. Inodilator because they are acted by two mechanisms, by inotropic mechanism like the digitalis and vasodilator like the other vasodilator drugs. That is why they are known as inodilator drugs. They are given by IV route. Action is started quickly, whereas in digitalis it was taking many hours even if we use the rapid mode. And it is, but the disadvantage is it is indicated only in the short term IV therapy in severe and refractory cases and is not used routinely, as we have already seen you in the diagram. For milder cases of congestive heart failure, we start with the ACE inhibitors, beta blockers, diuretics, and if not controlled, then we shift to the digoxin, IV vasodilators, or inotropic drugs. And ADR are thrombocytopenia, nausea, diarrhea, abdominal pain, liver damage. So this was all about the today's class. Now to summarize, we have done three main topics today: treatment of angina, MI, and CHF. Important points about angina are: what is angina? Substernal pain radiating to the left arm. Three types of angina: classical, variant, and unstable angina. Classical angina is due to atherosclerotic plaque. Variant is due to vasospasm, and unstable as component of both. The main drugs used in the treatment of angina are nitrates, which are effective in all three types of angina. Calcium channel blockers, beta blockers. Calcium channel blockers are again effective in all three types of angina. Beta blockers, they are not used in variant angina. And other potassium channel opener, nicorandil, which is mainly used for the prophylaxis. Short acting nitrates are preferred in acute angina, rest all are used in chronic angina. Trimetazidine and one trimetazidine, it acts by different mechanism, not acting through the heart rate or contractility or vasospasm. Second was MI. MI के अंदर it is the advanced stage of angina, irreversible damage to the heart. Here we give the symptomatic treatment first, maintain the airway, breathing, maintain the airway circulation, relieve the pain. Then we give the depending on the uh, depending on we give, if there is thrombi, then we give the thrombolytics. If it has not developed, then we prevent the development of thrombi by giving the antiplatelet drugs. Statins are given, ACE inhibitors are given to prevent the remodeling. Okay, for the treatment of arrhythmias, we again depending on the tachy or bradyarrhythmia, we give the drug. For bradyarrhythmia, we give the atropine or lactical pacing. For tachyarrhythmias, we give the lidocaine. Now the third topic was CHF. CHF is heart is not able to pump the blood. It may be of systolic reason or diastolic reason. Systolic is when heart muscle is not working properly, and diastolic when heart is not relaxing properly. Then the symptoms mainly of congestion related. Periphery can present as edema. In cases of lungs, they present as chest pain, dyspnea, and due to the forward failure, um, renal output is decreased, fatigue, CNS confusion may be there. So these are the symptoms which may be present in the heart failure. And for the treatment of heart failure, we have ACE inhibitors, beta blockers as the main drugs, digitalis and inodilators. They are called in later for the treatment. The inodilators are ambrinon, which have dual action as an inotropic as well as vasodilator action, and they are used only for the emergency control or in the refractory cases of heart failure. So, thank you for listening so patiently. Thank you.